Hello students, hope you're all doing good. In this video, we are going to discuss about Rh negative pregnancy. Okay. Now, before starting the discussion of Rh negative pregnancy, I want to discuss about various blood group systems. Okay. So, we know the blood group systems are classified based upon the antigens that are present upon the RBC. Okay. For example, we are more familiar with the ABO blood group system. It is classified based upon the antigens, namely A, B and O. Samely, we have a group of rhesus antigens, okay, namely capital C, capital D, small d and capital D, okay. So, based upon this, there is a rhesus blood group system. Likewise, there are more than 300 antigens are identified and 33 blood group systems are defined, okay. So, we have the blood group system. So, if this is the RBC, so many antigens on the RBC, okay. So, based upon this, it is classified, namely, first one is ABO group of system, second one is rhesus group of system, and you also have MNS, KIL, KID, okay, Lewis and Duffy, okay, and more, but these are the some of the important blood group systems we are going to discuss, okay. Now, among this, the chromosome for ABO blood group system lies on chromosome 9 and rhesus blood group system lies on chromosome 1, okay. First, we will discuss about the rhesus system, okay. So, as I have already said, the rhesus system is the second most important system after ABO. Okay. In the rhesus system, almost there are 50 defined antigens, but the most important ones are capital C, capital D, capital E and small e. Okay. Among this, the most potent antigen is D. Okay. So, based upon this only, we classify the mother as Rh positive or Rh negative. Okay. So, if the D antigen is present, then she will be called as a rhesus D antigen positive, that is Rh positive woman. Okay. Suppose if she doesn't have the D antigen, then she will be called as rhesus D negative, that is rhesus Rh negative mother. Okay. So, if this antigen is present or not present, she will be called as Rh positive and here it will be Rh negative. Okay. And remember, D antigen is the most immunogenic antigen. Okay. Now, we will consider three scenarios. Okay. Like we have a Rh negative mother and a Rh negative father and a Rh negative mother and a Rh positive father who is heterozygous for rhesus antigen. Okay. And in the third scenario, we have a Rh negative mother and a Rh positive father who is homozygous for Rh antigen. Okay. Now, in these three scenarios, if you see, the chance of getting a Rh positive baby in this scenario is really 0, right? So, mostly the baby will also be Rh negative blood group and this can be considered as a low risk pregnancy. Okay. Whereas here, in Rh negative mother and Rh positive father who is heterozygous for rhesus antigen, there is a 50% chance that the baby can be Rh positive and 50% chance that the baby is Rh negative. And here in the third scenario, there is a Rh negative mother and a Rh positive father who is homozygous for rhesus antigen. So, there is a 100% chance of Rh positive baby. Can you get it? Okay. Now, we can rule out this okay, this Rh positivity or negativity of the fetus antigen by doing cell-free DNA test. Okay, but remember, this test is very costly to afford for the patient, right? So what we are going to do is, whenever there is a Rh negative mother and a Rh positive father, okay, we are presuming that the baby is going to be Rh positive only, and these two scenarios will be considered as high risk pregnancies. Okay, clear? Yes? Okay. Now, we will see the other systems also which are immunogenic like this. Okay. So, other systems which are at risk of sensitization of mother. Okay. See, the risk of sensitization is more in KEL system, KIT system, then Duffy A system and MNS system. Okay. So, it is KEL, KIT, Duffy A. Okay, in Duffy system we have two antigens A and B. So, Duffy A is more risk and the MNS system. Okay, but the risk is lower. Okay, in case of definitely it is going to be Duffy B we know and Lewis system. Okay, so these two systems have low risk of sensitization. Clear? Now, ma'am, you are telling sensitization. Now, tell us what is sensitization and what is going to happen really. Okay, so we'll see first what is going to happen. Okay, see, there is a mother, okay, who's Rh negative, okay, and she is now going to carry a Rh positive fetus. Okay, by any chance, okay, by any chance, there is a small amount of feto-maternal hemorrhage going to happen. Okay, that is some blood from the fetus is going to the mother. Okay, then what happens? This is a Rh positive fetus. So anything that is new to the body is considered as an antigen, and our immune system is going to develop antibodies against it, right? So here these positive antigens, okay, these T antigens are going to come to the maternal circulation, and our maternal immune system is going to produce antibodies against it, right? Now, antibodies are produced in the mother. Okay. Now, what happens is these antibodies, okay, are going to target the fetus antigens. Okay. So, it is going to target the fetus antigens. Okay. So, initially what happens when the sensitization happens, it is only the IgM antibodies are produced. Okay. And after some 6 weeks to 6 months, the IgG antibodies are produced. Okay. So, initially when the IgM antibodies are there, the condition will be somewhat safe. Okay, because IgM antibodies are not going to cross the placental barrier. But we know the IgG antibodies are going to cross the placental barrier, and especially it is the IgG1 and IgG3. Okay, so these are going to cross the placental barrier and they are going to target the fetal antigens. Okay, now where the fetal antigens are present? Yes, on the RBC. So RBCs are targeted and they are going for hemolysis. Clear? Okay. So initially when this feto-maternal hemorrhage is going to happen, okay, the mother is sensitized. Okay, first thing happens is sensitization of the mother or sensitization of the immune system. Okay, by that time IgM antibodies are produced and it is taking 6 weeks to 6 months for IgG antibodies to get produced. The mother would have delivered the first baby. Okay, so most of the time the first pregnancy is uncomplicated. Okay, or the first baby escapes the sequelae. Okay. Now, these antibodies are going to survive in the mother for a longer time. Okay. Now, if she is getting conceived again, okay, and the same sequelae is repeating. Okay. Sorry, repeat. Now, we know these antibodies are going to be present in the maternal circulation for a longer time. Okay. Suppose she is getting conceived for the second time with the RH positive fetus again. What is going to happen? These antibodies in the maternal circulation is going to target the fetus from the earliest stage of life itself. Can you understand? And remember the fact that these fetal antigens on the RBCs are produced from early state of gestation itself from the yolk sac, and they can be seen as early as 38 days of gestational age. Okay. So, even from the state, the antibodies can target the fetal antigens. Can you get it? Yes. Now, if we see again, Indians have an incidence of 5 to 7% of RH negative pregnancy. And if you take in Chinese and Japanese, this is around 1%. Okay. Now, this makes a significant difference, and it is very important to know about this RH negative blood group and what are the complications that would arise and how you are going to manage if you have a RH negative pregnancy. Clear? Okay. Now, first we will start with the mechanisms, okay, by which the sensitization can happen. Okay. I told you about fetal-maternal hemorrhage, but not only during fetal-maternal hemorrhage, but if there is any incompatible blood transfusion that has been made to the mother prior, that can also lead to sensitization of the immune system, right? So, either after incompatible transfusion or fetal-maternal hemorrhage. And there are so many reasons for fetal-maternal hemorrhage, we will discuss it. But remember the fact that fetal-maternal hemorrhage during pregnancy, there is only a 10% chance, okay. But during labor, there is a 90% chance, okay. And this fetal-maternal hemorrhage can happen during labor or pregnancy. Okay, and remember, during pregnancy there is only a 10% chance of fetal-maternal hemorrhage, whereas during labor there is a 90% chance of fetal-maternal hemorrhage. Okay, so during pregnancy and during labor, okay, 90% chance, and this happens 10% chance. This can be further divided into trimesters. So, if you see in the first trimester, second and third trimester, there is a 56% chance, 63% chance and 71% chance respectively. Okay. Clear? Now, we will see some potentially sensitizing events. Okay. They may include abortions, invasive procedures. What are the invasive procedures we do on the fetus? Yes, chorionic villus sampling or amniocentesis. Okay. So, it is chorionic villus sampling, amniocentesis. Then, if there is any history of trauma or there is a antepartum hemorrhage due to any cause, like there can be a placenta previa or abruption. The risk is increased in case of multiple gestation, manual removal of placenta, there is ectopic pregnancy, during delivery, maybe by any modes, okay, or even an instrumental delivery. And in some cases, when we are planning embryo reduction or external cephalic version, and even in cases of IUD, okay, that is intrauterine death. So, in all these cases, there can be fetal-maternal hemorrhage, and remember that less than 0.1 ml of blood, okay. So, actually the risk depends upon number 1, the volume of fetal-maternal hemorrhage that has occurred. Then the extent of the maternal immune response. And if there is a concurrent ABO incompatibility also, okay, and remember, when there is a concurrent ABO incompatibility, the risk is going to reduce, okay, it reduces by 1 to 2%, okay. Now, to check the volume of fetal-maternal hemorrhage that has occurred, we can do either Clay or Bedke test or flow cytometry, okay. And to find the extent of maternal immune response, that is whether the mother is sensitized or not, we will be doing indirect Coombs test. Now, we will see about Clay or Bedke test. This test is also known as acid elution test. And remember, it is a standard test and it is a quantification test. Quantification means we will be quantifying the amount of fetal-maternal hemorrhage that has happened. Now, in this test, what we are going to do is, we will be taking a smear from the maternal blood and we will be subjecting the smear to acid, okay. So, the acid that is used in Clay or Bedke test is citric acid. Now, remember the fact that HbF, that is the fetal hemoglobin, is resistant to acid elution, whereas HbA, that is the maternal hemoglobin, is not like that, okay. So, when it is subjected to acid bath, it will be soon disappearing from the smear, okay. So, you are preparing a smear and you are subjecting it to acid bath, and finally you are doing some staining procedure also, okay. So, after staining, if you see, the hemoglobin in the fetal RBC cells will be retained and it will be seen as a bright red color, whereas the hemoglobin in the maternal RBCs would have been lost already. So, it will be appearing as ghost cells, okay. Can you understand? Then what we will be doing is, we will be calculating the number of fetal RBCs as a percentage and we will be quantifying the amount of fetal blood that has entered into the maternal system, right. Now, we will see the principle behind this Clay or Bedke test, okay. So, in this test, you have to remember the fact that HbF, that is the fetal hemoglobin, is resistant to acid elution, okay. So, what we will be doing in Clay or Bedke test is, we will be obtaining a maternal blood sample and this blood sample will be smeared and it will be subjected to acid elution. The most common reagent that is used in Clay or Bedke test is citric acid. So, when it is subjected to acid reaction, only the fetal hemoglobin is going to remain and the maternal hemoglobin is going to be washed off, right? Now it will be subjected to further staining by Shepard's method, where the fetal RBCs will be appearing in rose pink color and the maternal hemoglobin is lost, so that maternal RBCs will be appearing just like goose. Can you clear? Now we will be calculating the fetal RBCs as a percentage to the maternal RBCs, and we will be calculating the volume of fetal-maternal hemorrhage that has occurred. Clear? Yes. I will tell you once again. Remember the fact that fetal RBCs are resistant to acid elution. Okay. So first we are preparing a smear from maternal blood. Okay. Then subjected to acid bath or acid elution, and the reagent is citric acid. Okay. Then it is staining. Okay. The staining method is known as Shepard's method. Okay. So HbF means HbA lost. So on further staining, HbF appears in rose pink color, okay, whereas HbA appears as ghost cells. Can you see? So these are the fetal RBCs, okay, and whatever you see here and all, these are the maternal RBCs, okay, that has lost the hemoglobin, and they are known as ghost cells. Clear? Yes. Now, we can also do it by flow cytometry. This is also one of the standard and accurate test, and it is more accurate than Claire-Bedke test. Okay. Standard, more accurate than Claire-Bedke test. So this can be considered as a best test also. Okay. Here we can even quantify a large number of fetal cells. Okay. What we'll be doing is we'll be using the monoclonal antibodies. In flow cytometry, we are going to use monoclonal antibodies against HbF or the D antigen itself, and then we are going to subject the sample to fluorescence. Okay. So, we will be using monoclonal antibodies to HbF or D antigen, and it is subjected to fluorescence where it will be quantified. Okay, quantified by fluorescence. Can you get? Okay. So this is how we calculate the fetal-maternal hemorrhage. Now, till now we have seen what are the causes of fetal-maternal hemorrhage and how we are quantify the amount of blood that has entered into the maternal circulation. Now, we have to check whether the mother got sensitized or not. What is the test we are going to do? Yes, it is the indirect Coombs test. Okay. The indirect Coombs test can be positive if the mother is sensitized, and it will be negative if the mother is not sensitized. Okay, simple. So, what does positive means? Mother sensitized, and negative means the mother is not sensitized. Okay. Suppose if the mother is not sensitized means will be giving anti-D immunoglobulin to prevent sensitization. Okay. Suppose the ICT is positive, there is no role in giving anti-D. Okay. But we should know about the sequelae of events that will occur. Okay. And we have to follow up with various other investigations. Okay. First, let me explain the sequelae of events. Okay. We know the fetal blood is going to enter into the maternal circulation, and the maternal circulation, first IgM antibodies are produced which are not going to cross the placental barrier, right? Then after 6 weeks to 6 months, IgM antibodies, especially the Ig1 and Ig3 are produced. These are going to cross the placental barrier. Okay. Now, these are going to cross the placental barrier, and when they are already there in the second pregnancy, they are going to start attacking the fetus from the earliest stage itself. Okay. So, it is going to target which cells now? Yes, it is the red blood cells. So, when red blood cells are targeted, what is going to happen? There is fetal anemia. Okay. So, whenever there is fetal anemia, this is the first presentation we will be able to see when we are monitoring it during the antenatal period. Okay. Whenever there occurs fetal anemia, it will be followed by what? To compensate it, there will be extramedullary erythropoiesis, and especially this will be taking place in the, yes, very good, in the fetus it will be taking place in the liver. So, there will be hepatic enlargement. Okay, whenever there is hepatic enlargement or hepatomegaly, what is going to happen? There is hepatic dysfunction also. So, this hepatic dysfunction is going to cause a decreased amount of protein production. Okay, and this decreased amount of protein production is going to reduce the plasma oncotic pressure. So, what happens? There is more accumulation of interstitial fluid. Yes, so this fluid will be accumulating everywhere. Okay, it will be accumulating in the subcutaneous tissue. It can accumulate in the pericardial space, pleural space, even in the scalp tissues. Everywhere it is going to accumulate. Okay, and ascites also is possible. Okay, so overall the baby comes swollen with more amount of fluid accumulation everywhere in the body, and this condition is known as, yes, it is Hydrops fetalis. Clear? Okay, and also remember the fact that whenever there is hepatic dysfunction, this is also going to raise the portal hypertension and umbilical hypertension. Okay, and this hypertension may also cause heart failure. Clear? And another fact is that when RBCs are getting lysed, what is going to happen? There is release of, yes, heme. This heme is going to be acted upon by heme oxygenase to produce biliverdin, and biliverdin will be further acted upon by biliverdin reductase, okay, to form bilirubin. So, there is a state of hyperbilirubinemia where the patient will be presenting, where the fetus will be presenting with jaundice, and it is also neurotoxic. Clear? Now, we will write the sequence of events. I hope you would have understood and you can come up with me together, right? Yes. So, IgG antibodies in the mother. Okay. So, first thing what is going to happen is fetal RBCs are lysed, that is hemolysis happens, and because of the hemolysis there is extramedullary hematopoiesis, especially hepatic erythropoiesis. So, because of the increased function in the liver, there is hepatic dysfunction. So, there is impact protein synthesis. So, there is a decreased plasma oncotic pressure. So, there is increased interstitial fluid, and there will be Hydrops Fetalis. Okay, and also this hepatic erythropoiesis is also going to cause portal and umbilical hypertension, that is also going to result in hepatic failure. Okay, and another fact is that yes, the heme is released, which will be converted into biliverdin by hemoxygenase, and we also know that heme will be released, which will be acted upon by hemoxygenase and will be converted into biliverdin, and biliverdin reductase will act upon this and convert them into bilirubin. Okay, so there is a state of jaundice, okay, due to hyperbilirubinemia. And remember the fact that, okay, so these status also can affect the placenta, and there can be placentomegaly. Okay, due to this placentomegaly, the mother may even present with PAH features. Okay, in the mother, there can be PAH features, and it will be accompanied by polyhydramnios also. Clear? Yes. Now, if we take fetal anemia, the hemoglobin falls by 1% per day. Okay, so hemoglobin falls by 1% per day. That means 7% per week. Okay, and it will be around 3.3 grams of hemoglobin per week will be lost. Okay, so Hydrops Fetalis occurs when the hemoglobin becomes less than 5 gram percentage and the hematocrit becomes less than 15. Clear? And remember the fact that whenever there is Hydrops Fetalis, the recurrence risk is about 90%. Okay, so recurrence risk of Hydrops Fetalis is 90%. Okay. See, Hydrops Fetalis can occur due to immunogenic cause, as we have seen in Rh negative pregnancy, and it can occur due to some other non-immune causes also. Okay, and remember, non-immune causes are more common than immune causes. Okay. Can occur due to immune causes or non-immune causes. Most of the time, erythroblastosis fetalis is given for immune causes. Okay, where we call as erythroblastosis fetalis. Okay, and non-immune causes are more common than immune causes. Okay. So, what are some of the non-immune causes we can tell? Okay. Non-immune causes, cardiac causes are the most common non-immune causes. Okay. So, cardiac causes that may include cardiac arrhythmia, cardiomyopathies, okay, or there can be a coarctation of aorta or any left side obstructive lesions. Okay, so these are the most common cause of non-immune. Next, there can be chromosomal causes also, that may include all your trisomies like 13, 18, 21, even your monosomy, that is Turner syndrome, and Noonan syndrome also. Okay, and infectious causes may include parvovirus infection, cytomegalovirus infection, syphilis, toxoplasma listeria. Okay, and in cases where fetal anemia can occur, like thalassemia, especially the alpha thalassemia, G6PD deficiency, and some of the thoracic causes like congenital cystoadenoid malformation, chylothorax, and diaphragmatic hernia. Not only in this, when there is a multiple pregnancy, in twin-to-twin transfusion syndrome also this can occur. Okay. So, this list is not complete, but these are some of the important causes, and remember the cardiac causes are the most important non-immune causes of Hydrops fetalis. Okay. Now, as we have already seen, what are the features of Hydrops fetalis? So, when we take Hydrops fetalis, okay, features include number 1, there will be subcutaneous tissue edema. Number 1, it includes subcutaneous tissue edema. Number 2, yes, ascites can be there. Then pleural effusion, pericardial effusion, scalp edema. Okay, and it may also result in hepatosplenomegaly and congestive cardiac failure. Okay, and remember the first 4 features are the most important features. Okay, subcutaneous tissue edema, ascites, pleural effusion, and pericardial effusion. These are the most important features of Hydrops fetalis. And among these 4 features, if you have more than or equal to 2 features, okay, then you can make a diagnosis of Hydrops fetalis. Okay, so diagnosis can be made. Clear? Now, what is going to happen in mirror syndrome or Ballantyne syndrome is the fetus and the mother are going to be a mirror image of each other. Okay, so there is basically edema in the mother as well as edema in the fetus. Okay, so edema in the fetus is Hydrops, and there is going to be edema in the mother also, and the placenta is going to be edematous also. Okay, so basically we can call it as triple edema. Okay, where there is edema in the mother, placenta, and fetus. Okay, and remember the fact, sometimes this may mimic a case of severe preeclampsia also. Okay, but the important differentiating feature between severe preeclampsia and mirror syndrome is that there will be low hematocrit in the mother. So basically there will be hemodilution in the mother. Okay. Okay. Whereas in severe preeclampsia, there will be hemoconcentration. Okay, so this is one of the important differentiating feature. Okay, and mirror syndrome can occur in any cause of Hydrops fetalis. Okay, now we'll see some antenatal investigations. That are used to rule out fetal anemia, because that is the very first step that is going to happen in Hydrops fetalis, right? Even while doing a CTG or NST itself, you will be able to diagnose fetal anemia. What is the pattern of CTG that you will be seeing if there is fetal anemia? Yes, it is sinusoidal pattern. Okay. Okay. Sinusoidal wave pattern means you will be having a picture like this. Clear? So, we can do Doppler investigation also, where we will be studying the middle cerebral artery flow, especially the peak systolic velocity. Okay. Now, if you ask me, ma'am, why there is a increased middle cerebral artery flow in fetal anemia? Because whenever there is a fetal compromise is going to happen due to any cause, okay, the system tries to save the brain of the fetus first, right? So, there is auto-regulation that is happening in the brain, that is also known as brain sparing effect. So, more amount of blood will be shunted towards the brain and there will be splanchnic vasoconstriction everywhere, okay. So, auto-regulation or brain sparing effect. Okay. So, there is increased blood flow to the brain and everywhere else there is splanchnic vasoconstriction. Clear? And in the ultrasound, you will be able to make out signs of Hydrops fetalis also. Okay. So, there will be edema everywhere, right? So, there can be edema around the scalp, edema around the extremities, there can be pericardial fluid collection or pleural fluid collection, ascites and all. Okay. So, USG features of Hydrops fetalis. So, if you take the USG features of Hydrops fetalis, okay, so there can be scalp edema, that is first visible sign that is seen in the case of Hydrops fetalis, okay. So, this sign is also known as, since it is looking like a halo around the head, it is also known as Buddha sign, okay. So, this is a feature of Hydrops fetalis we will be able to make in ultrasonogram. Before using ultrasonogram, we were previously using a chart called as Lilly's chart. In this chart, what we will be doing is, we will be plotting the gestational age of the fetus in weeks to the amniotic fluid bilirubin levels. This amniotic fluid bilirubin levels will be measured by spectrophotometry and specifically they will be demonstrable at an optical density radiance range of 450 nanometer. Okay, and the fetal anemia will be classified into 3 grades and the chart will be also divided into 3 zones respectively. Okay, so if we take Lilly's chart, so we'll be measuring the amniotic fluid bilirubin levels by spectrophotometer at an optical density range of 450 nanometer and we'll be plotting a graph between gestational age in weeks to the amniotic fluid bilirubin levels. Okay. So, this is how the chart will be plotted and you have a low zone, middle zone and a high zone here. Okay, which means that there is a mild fetal anemia, there is a moderate fetal anemia, and here it means there is a severely affected fetus. Okay, and the fetal death is also imminent. Okay, fetal death can occur at any time. Clear? But we are not using Lilly's chart anymore since we have the non-invasive ultrasonogram measurement of middle cerebral artery peak systolic velocity. We are not using Lilly's chart anymore. Okay, but we have to know just what is Lilly's chart and how it was classified accordingly. Okay, so the ultrasound of middle cerebral artery peak systolic velocity is one of the accurate and non-invasive screening test detects fetal anemia in different rates from mild to severe. Okay, and also there is 80% reduction in invasive procedure. Okay, like as we have seen the Lilly's chart, there is no need for amniocentesis. Now we will see in order how we are going to take a RH negative pregnancy from first. Okay, so whenever there is a RH negative mother, we will be asking the history of the blood group of the partner. Okay, so when it is RH negative, then you can advise her for routine ANC follow-up. Okay, suppose if the partner is RH positive, then we'll be subjecting them to, yes, what test? Indirect Coombs test. Okay, and if the indirect Coombs test is negative, there is no sensitization. So we'll be doing only the preventive measures. Okay. Suppose if the ICT is positive, that means the immunization already occurred. Okay. Then we have to go for titer determination. Okay. See, in the ICT titer, there is a critical value of 1:16. Okay. So whenever it is more than 1:16, the titers, then they can cross the placenta. Okay. So in this case, when the titers are more than 1:16, okay, you have to monitor for fetal anemia. Okay. Suppose if the titers are less than 1:16, then you have to monitor for, since the ICT is positive, you have to monitor every twice weekly. Okay. And you have to plan delivery at around 37 weeks itself. Okay. Now, how will we be monitoring for fetal anemia? Yes, it is MCV Doppler. So, we will be doing middle cerebral artery peak systolic velocity Doppler, and in that, if it is less than 1.5 multiples of median, then you can deliver them around 37 weeks. Suppose If it is more than 1.5 multiples of median, then fetal anemia is surely present. Then you have to go for fetal blood sampling. Clear? So, if there are any signs suggestive of any one of the following, okay? For example, there is a severe fetal anemia that was found in ultrasonogram, or there is a middle cerebral artery peak systolic velocity that is more than or equal to 1.5 multiples of median, and even an increased ICT titers, okay, more than 4 folds than the previous titer. Remember the fact that ICT titer is done at first visit and at least repeated once after that, okay, 28 weeks, okay. And suppose if it is positive, okay, in the first visit itself, then it should be repeated. Now we will see about anti-D, immunoglobulin, okay. Mostly we will be assuming that the dose of anti-D immunoglobulin is around 300 micrograms or 1500 international units, okay, considering there is a feto-maternal hemorrhage of 30 ml or there is 15 ml of fetal RBCs. Clear? And if there is more amount of feto-maternal hemorrhage that has happened in case, so for every more than 30 ml of feto-maternal hemorrhage, for 1 ml we will be adding additional 10 microgram units of and suppose if there is more than 30 ml of feto-maternal hemorrhage happened, okay, we will be adding for every 1 ml above that, we will be adding some 10 microgram of anti-D additionally, okay, and anti-D is given as an IM injection. It can be given in the deltoid muscle or the anterolateral aspect of thigh. Mostly, the standard dose of 300 microgram will be covering 99.7% of the patients. Okay. If you see the prophylactic dose of anti-D that will be giving in a ICT negative woman, it is 300 microgram that is given at 28 weeks of gestational age, okay, and it also be given after birth, okay, within 72 hours of delivery, and it can be given up to, ideally it must be given within 72 hours of delivery, but it can be given up to 28 days after birth also. And when you do fetal blood sampling, when the anemia is severe, that is the fetal hematocrit is less than 30%, you have to see whether the pregnancy has crossed more than 35 weeks. If it has crossed over 35 weeks, you can immediately plan delivery, okay. Suppose if it is less than 35 weeks means you can plan on fetal transfusion. Okay. Suppose the hematocrit is more than or equal to 30%, that means there is no fetal anemia or only mild fetal anemia, then you will do hemoglobin and hematocrit weekly, and when it goes below 30%, you have to deliver it immediately. If not, you can deliver around 37 to 38 weeks of gestation. Okay. And remember, cesarean section is only for obstetric indications. You can plan the mode of delivery as vaginally itself. Clear? And after delivery, early cord clamping is done when there is a RH negative mother with ICT was also negative. Okay. And you can even do delayed cord clamping in a RH negative pregnancy when that was a RH negative pregnancy with ICT positive, because already sensitization has occurred, right? So, now we will see some points on fetal blood transfusion also. So, ideally it can be done as a intrauterine transfusion. Via the umbilical vein or intrahepatic vein, or intraperitoneal transfusion is also possible, and mostly it can be done between 18 to 35 weeks of gestational age, and most commonly will be using O negative group. Okay, so this is the choice. Okay. Now, there are complications of fetal transfusion also. There can be fetal demise, chorioamnionitis, placental abruption, or it can even result in preterm labor also. Okay. So, these are some of the complications of fetal transfusion. I hope we made this clear. We have studied about the blood group systems, what is RH negative pregnancy, what are the various investigations we have to do, what is antibody, what is the dose, and when you have to give it. Okay. And also we have studied about the ultrasonogram findings. Okay. And finally about the fetal anemia and fetal blood transfusion also. Okay. So, until we meet in the next video, take care, happy learning, and bye-bye.